Hi, this is Dr. Larmer, and I'm going to do a lecture now on antihypertensive drugs. These are medications that we use to treat hypertension. So we use these medications when we want to lower the blood pressure of the patient. This lecture slide set has about 95 slides in it, so I'm going to talk for about 15 minutes and take a break and try to break the lecture up a little bit. So here we go. The first thing that we need to understand about antihypertensive drugs is to understand about blood pressure and what makes up blood pressure. So blood pressure, if we think about it in a formula, is really cardiac output times systemic vascular resistance. So if we think about cardiac output, we're thinking about how much blood is ejected from the heart. If we think about systemic vascular resistance, that's talking about the blood vessels, and it's really talking about how dilated or open a blood vessel is, or how constricted or closed a vessel is. So if you think about systemic vascular resistance, the higher the blood pressure, or the more difficult it is for the blood to move through our blood vessels or through the pipes in our body, the higher the resistance is. And oftentimes then the higher the blood pressure will be. There's a video on hypertension here that I would like you to watch. If you can open that link, I think it'll give you kind of a nice summary about or a recap on hypertension. I know you're learning about it in your med-surg class, but if you can, link into that and watch that to get an update on to get a fuller picture on hypertension. So when we treat high blood pressure, or we look at blood pressure and what increases or decreases blood pressure as far as medications are concerned, we think again about cardiac output and systemic vascular resistance. And what we're going to talk about for this lecture is all of these medications, or at least most of them, and how they affect blood pressure. One thing that we know about blood pressure is that usually takes more than one, and actually an average of about 3 medications before we can adequately get someone's blood pressure to an acceptable or normal level. So even if we treat with one of these medications, like a beta blocker, we may still need to treat the patient with an ACE inhibitor in order to get the blood pressure where it needs to be. And we're going to talk about each of these drugs or categories of medications and how it affects blood pressure. What I would encourage you to do is, after we finish this lecture, is to go back to these slides and look at cardiac factors, circulating volume, and try and refresh yourself on how all the medications we just talked about, what categories they fit into. So our classifications of blood pressure. We know that hypertension can also be defined by its cause. An unknown cause would be an idiopathic cause. That's about 90% of our cases of hypertension. We really don't know why the person has high blood pressure. We know what the contributing factors can be, but we really don't know that there's a specific cause. And we call that primary hypertension. A known cause would be secondary hypertension, and that's only about 10% of our cases. That might be something like an obstructed artery to the kidney that may cause us to have high blood pressure. Usually these secondary hypertension cases we can fix or do something about the source of the hypertension, and then the hypertension will resolve. But with most cases, by far and away, we consider it primary hypertension or idiopathic hypertension. And you can see just how many people in the United States are affected by high blood pressure or hypertension. About 32% of all African Americans have hypertension. It's something that is number one on the agenda of things that the American Heart Association wants to do something about to improve the state of hypertension in the United States. When I met with the director of the CDC the other day, he mentioned that that hypertension is high on their list of things to try to address. And what's really frightening is that although 70% of people are aware of their condition, only 50% of those that are aware are receiving any kind of treatment for it. So people are tending to go around with either undiagnosed hypertension or hypertension that isn't being adequately treated. And we know that the troubling thing about that is it results in heart attacks and stroke, which can be life-ending or definitely life-changing and debilitating. Okay, so hopefully you've gotten some background on hypertension in your medical surgical class, and you've read maybe hopefully the beginning of the chapter on the hypertensive drugs. And now we're going to dive right in and talk about how do we manage hypertension. There's several categories of medications. They're listed here, and I'll go over each of these categories in depth. So I do want to go back a little bit to the physiology of hypertension. And again, this is just another slide that you can refer back to kind of when we're done with all of the talk about hypertensive drugs or antihypertensive drugs, and really go back and look and see where each of these medications that we're going to talk about, where they fit in to the physiology of hypertension. So again, like I mentioned here, if we talk about beta adrenergic blocking drugs, we talk about them working on the heart muscle here. If we talk about direct vasodilators, we're talking about things like sodium nitroprusside, which is a nitrate, and it works on the blood vessel. So I think this is an excellent slide that may look a little overwhelming right now, but I think when the lecture's done and you're stepping back to study a bit, you'll find this very healthy or very helpful about how these medications affect different organs. So let's talk first about diuretics. Diuretics are very commonly prescribed, and what they do is basically just accelerate the rate of urine formation. They make us urinate. What happens, though, is when we urinate, we remove sodium and water from the body. When we do that, we basically decrease our plasma and extracellular fluid volumes. So what that is to say is if you think about the heart as a pump, as it is, and the pipes as the plumbing in our system, and fluid flowing through those pipes, and the pump of the heart pumping that through. If you have a system, an engine or a pumping system, where the fluid in the tank gets lower and lower and lower, generally what happens to the pressure is what? The pressure is going to get lower. You've lost that fluid volume, and so the pressure becomes lower. And so that's the whole reason that we use diuretics. We get the extra fluid out of the body, out of the blood vessels, and it lowers the blood pressure. So what comes with that is decreased preload. That's the volume that goes into the heart. We decrease that. We get decreased cardiac output, and we also get some decrease in peripheral resistance. The overall effect is decreased workload of the heart and decreased blood pressure. So you get that fluid out of the system, and it's going to decrease blood pressure, and that's how diuretics work. We also get rid of sodium when we take diuretics. So in the nephron, where the sodium goes, remember, water will follow. So if we get rid of the sodium, we're going to get rid of the water as well. If the water isn't absorbed into the body, then it's excreted in the urine. And this is just a graphic or figure on how different diuretics work at different parts of the renal tubules. I don't really think you need to memorize this, but suffice it to say that when we talk about loop diuretics in a minute here, you can see that they work in the ascending loop of Henle, that the thiazide diuretics work in the distal tubules, and potassium sparing work a little bit further down the distal tubule. So it's kind of important to know that they work definitely in the renal tubules, because that's where we excrete or absorb sodium and water. So So next we're going to talk about the types of diuretics. The diuretics that we're going to focus on when we talk about hypertension are the loop diuretics, the potassium-sparing diuretics, and the thiazide or thiazide-like diuretics. So we'll talk first about thiazide diuretics. The thiazide diuretics are by far and away the most commonly used diuretics for hypertension. We call them first-line antihypertensives. In other words, if you're diagnosed with hypertension, the first medication that they're going to put you on is a thiazide diuretic. I don't know if they talk about this in Med-Surg, but JNC7, Joint National Council on Hypertension, number 7, that's their most recent guidelines. There may have been a JNC8 that came out, but I don't know that people are officially adopting it yet. And in that guideline, it tells physicians and nurse practitioners that this is the drug we use first, thiazide diuretics. These diuretics, or your exemplar drug, is hydrochlorothiazide, and this is the brand names for it. Hydrochlorothiazide is very commonly used, and we abbreviate it as HCTZ. That's capital H, capital C, capital T, capital Z, HCTZ. And we also use thiazide-like diuretics. These act like thiazide diuretics, like metolazone, which is Zeroxylin. But the exemplar drug you really need to know is hydrochlorothiazide. That's a thiazide diuretic. So how do they work? They work by inhibiting the tubular reabsorption of sodium. So remember we talked about the renal tubules. If you don't absorb the sodium and the sodium goes out, water goes with it. So you excrete the sodium, you're going to excrete the water. Action, as I mentioned before, is primarily in the distal tubule. And what happens? We lose water and sodium, and some chloride too. Potassium's also excreted, but to a lesser extent. We don't worry quite as much about losing potassium with thiazide diuretics. The nice thing that thiazide diuretics do is you get a little bit of arterial dilation with thiazide diuretics. We're going to talk more in just a few minutes about how thiazide diuretics or how our antihypertensive drugs can dilate our arteries, but you can imagine that if the pipes in a system open up and get bigger, the pressure also goes down in the pipe. So these thiazide diuretics dilate a little bit. The most important thing to know about thiazide diuretics is that it keeps us from absorbing sodium, so we excrete the sodium and we excrete the water. So the drug effects for thiazide diuretics is it lowers that peripheral resistance. Remember I said it lowers a little bit, it lowers the pressure a little bit by dilating the vasculature, and then we get rid of sodium and water. One caution or contraindication when using thiazide diuretics is that they shouldn't be used if people have poor kidney function. You do need the kidneys to be working pretty well when you're going to use thiazide diuretics. And this can be a problem because if people have had long-time hypertension, a lot of times they have poor kidney function. So how do we monitor kidney function? We monitor it by looking at creatinine clearance. When creatinine clearance is poor, we sometimes don't use thiazide diuretics. When do we use thiazide diuretics? We use it for hypertension, as I mentioned before. We use it as it's a first-line drug for hypertension. We also use it when people are edematous, so if they have peripheral edema or swelling in their extremities, we can use it. And sometimes we use it as an adjunct or an additional drug to treat edema when people have heart failure. But by and large, we use it for hypertension. The adverse effects of thiazide diuretics can really be mainly dizziness and headache, some blurred vision that we see in the central nervous system. I've really put in bold here the side effects or adverse effects that are most typical or most concerning with these types of medications. We also see problems with low potassium, some perhaps imbalance of blood sugar, some high blood sugar. Whenever we use a diuretic, we're always concerned about what it's doing to a person's blood sugar, especially if they're diabetic. Those fluid changes can change the concentration of any solute, which would be like glucose or sodium or potassium, in the blood volume. So as our volume of fluid in our vasculature goes up and down, it can change how much sugar is in our bloodstream. It can, and we also, again, eliminate some potassium so people can get hypokalemic. And this is actually, I might have misspoke. This is blood sugar, or sugar, not blood sugar, but sugar in the urine.